Since we do not have any more questions, I would like to invite our next speaker, Dr. Soumyadeep Ghosh from Bangalore Institute of Neurosciences. Soumyadeep, please.
So good evening, my respected teachers and my fellow colleagues who are presented here. I am Dr. Soumyadeep Ghosh from Biman, Kolkata, and I will be presenting a case of a tale of fragile blood. So this young female patient who attended a hospital last year, March 24, with an episode of febrile illness. And 5 days after that febrile illness, she developed acute onset of complete hemiparesis and 2 episodes of GTCS. She was brought to a defined medical college in Kolkata, and there she was evaluated. Along that, she developed aphasia and was admitted in that hospital, was treated, but the weakness improved almost completely over the next 1 week. But the fever persisted, and so she was admitted in the neuromedicine department of that hospital and was evaluated also for the fever. On the time of admission, there was an initial CT scan which obviously ruled out any hemorrhage. Then a MRI was done which showed that there is an acute infarct in the watershed area of the left side, and that corroborated with the clinical findings that she presented with. Also, their angiogram was done, and that revealed that left M1 is totally occluded, and there was no distal collaterals also. So the type of stroke and the angiogram features, images of the stroke were clear till now. But when they evaluated for the febrile illness, the chronic, the continuous febrile illness, they saw that the scalp typhus IgM was positive. However, incidentally, there was a hyperbilirubinemia with anemia. And when they evaluated that with the help of HPLC, EMA binding test, and the help of osmotic fragility test, they consulted the hematology department of that hospital, and the hereditary spherocytosis was diagnosed. That's because there is also important family history. Her mother told that her father died at the age of 32 due to a sudden stroke, and no evaluation could be done at that time due to their financial constraints or whatever so it be. Also, the other causes of stroke was ruled out, as we do in a case of stroke in a young individual, and those even the cardiac evaluation also was negative. So the patient was discharged from that hospital when the patient was treated for the febrile illness, and the weakness gradually improved. She was at home, lost follow-up for the next few months, and came to our hospital through her one relative. And then we rehabilitated the case, and then we thought that what could be the cause of the stroke in that young female during that febrile illness. So that may be an infective arteriopathy, focal arteriopathy leading to the stroke, or that may be any the blood dyscrasia that was incidentally found that causes any secondary murmur syndrome. So we thought of seeing the blood vessels now after the 7 or 8 months. So we do the CT angiography of the brain in our institute, which revealed the earlier left-sided M1 occlusion and also the right-sided proximal M1 narrowing was noted at this time, which was not there previously. So we also thought of doing DSA in our institute, and also we did that, which revealed. So this was the DSA video that we did in our institute, and it also showed that the right-sided MCI is also involved this time. So when there is a bilateral involvement of the MCI, the previous cause of infective arteriopathy was ruled out. We have already ruled out the non-infective primary any vascularity cause due to the blood or the other investigations. Still, a secondary murmur syndrome was still to be considered. So we took the help of MR vessel wall imaging that could give us some insight about the pattern of the involvement of the vessels. So this time again we did a MR vessel wall. The angiogram showed what I already told previously. Now in the MR vessel wall imaging, the pre-contrast T1 sequence is showing that the MCA is having concentric involvement of the vessel, and in defined cuts with defined MIP thickness, and in short axis it revealed that there is the MCA thickening. And when we did our post-contrast 15-minute imaging, there it showed that very minimal grade 1 concentric enhancement of the same MCA which we had the thickening in the pre-contrast study. So after doing the vessel wall, anybody will ask that what's the importance of doing vessel wall in this case, whether it is of any importance or not. So here the take is that hereditary spherocytosis does not cause Moama syndrome usually as per our textbook guideline or our textbook teaching. So when we are finding such a case with a rare co-association, whether we will consider or not. So in this case, if we think that when we will try to explain what was the cause of the stroke, infective cause was not there because that was unilateral involvement at that time. After 7 months, there was bilateral involvement. Second, vessel wall imaging ruled out any vasculitis cause because the pattern of the vessel wall imaging and the pattern of the involvement of the vessel wall was not going with any sort of vasculitis. So it was going with any form of non-infective or non-inflammatory involvement of the vessel wall. So the hereditary spherocytosis may be one of the cause causing a secondary Moama. So we tried to find and we tried to review the literature that was available in the net, and we saw that there are already 4 to 5 reported cases in world literature showing that with hereditary spherocytosis, Moama disease can occur, and these are mainly prevalent in the age group, pediatric age group, and one case also above 12 years in the age of 14. So again, the next question that will come from the audience that, okay, fine, that is a very rare association. Why will I know that, or why will I try to know that? Because of the fact, most of the cases that they have described in the literature, they are the patient had recurrent episodes of TIA or stroke, and they did the treatment because there is no study or there is no study available till now because it is a rare association. So they did that splenectomy or the treatment of anemia, vigorous treatment of anemia, helped to stop the recurrent TIA or the recurrent stroke in those patients. So if I can show that in a patient with hereditary spherocytosis with stroke, the vessel was imaging is suggestive of secondary Moama, then I have to go to the treatment part where I have to prevent the anemia, and I have to also do a splenectomy if the patient has enlarged spleen. So that is also an importance whether their treatment consideration is there. And regarding the cause, why it causes secondary Moama in hereditary spherocytosis, the literature that is available, and 2 scientists that already have shown in some mice with mutated spherocytes, they have told that increased hemolysis causing chronic hypoxia, and that causes endothelial damage with proliferation of the endothelial lining causing the Moama pathology, or that we see in Moama. And also that increased blood flow with the less deformity of the RBCs causes endothelial proliferation, takes the help of the nitric oxide scavenging due to the hemolysis, all causing a vessel wall thickening and the stenosis, ultimately leading to stroke during any sort of crisis in infection or any sort of crisis period. So the take home message in this case is that when we are seeing a case like this, don't rule out that, okay, that does not occur in textbook, it is not written. We have to think about that, and vessel wall imaging here in this scale helped us to rule out the vasculitis pattern, and also helped us to show that it is the vessel wall involvement is due to a non-infective or non-inflammatory pathology, and most likely due to hereditary spherocytosis. The patient is on a follow-up. She comes to our stroke OPD, and we will see how she reacts with the optimal treatment and what happens in the next. Thank you.